Hello, good evening. Welcome everybody to my IVF&x and the European Fertility Society. We are back once again with another topic to discuss today. Thank you so much for joining everyone. I hope you had a nice day and are ready to listen to some very interesting things that we are going to discuss for sure. Thank you so much, Dr. Harry Karpouzis is with us. Thank you so much for joining us. How are you? It's great to have you back.
I'm fine, Caroline. Nice to see you again. And I hope it will be interesting for everybody. It's a difficult topic and for specific, category of subfertile patients. I will try to make it as simple as possible because it's not easy, and we'll see.
That's our aim, definitely, just to bring this to you. NK cells, immunology, those topics are never easy. And I'm sure you will have lots of questions. And again, those questions probably will not be easy to answer because this subject is definitely still not fully understood, I think. So thank you so much for bringing this up to today. And of course, we will start with the presentation on this. And Dr. Harry Karpouzis will definitely try to explain as much as possible. And then we will go for your questions. As always, please put those in the chat. And Dr. Karpouzis will simply answer them for you one by one. And before we start with the presentation, let me just briefly also introduce our patient-centered care clinic program that has been just started. And of course, we are very proud to be able to introduce this to you. This is the first patient-centered care clinic program that exists. So we are really proud to be able to bring this. And if you wish to find out which clinics already had a chance to go through the full process of receiving this certificate, you can go to myivfenses.com and you will find out which clinics already have it. And of course, if you'd like to find out a little bit more details on this, I can again encourage you to go to myivfenses.com and you will find more details on that as well. So now I don't want to keep you waiting. Let's go ahead with our presentation. And remember, we are here for you. It's all anonymous, so don't hesitate. And you can type the questions during the presentation or afterwards. All right, Dr. Harry, ready?
Yes.
Brilliant. Thank you so much. Let's go.
Okay. Hello to everybody. I'm Harry Karpouzis. I'm the scientific director of Pelargos IVF. We are a fertility group clinic based in Athens, in Greece. We will talk today about natural killer cells and generally immunology. Quite difficult topic that is not for everybody. First of all, let's start talking about natural killer cells. What are these cells? First of all, we have the natural killer cells that are in the blood, and we have the uterine natural killer cells, which actually is the main immune cell in the lining of the womb. And it's not about the cell, actually. Its main role is to help implantation and early pregnancy, and to help creating the early stages of pregnancies, of the vessels, the placenta, and is doing that by producing some substances that are called cytosins. Now, regarding the uterine natural killer cells, we need to determine, first of all, that they are different from what we have in the blood. And the blood natural killer cells do not always correspond to what is happening inside the womb, which is what it really matters. We know for sure that the natural killer cells are important for the implantation, but when the numbers are getting raised or reduced, we don't know exactly the levels beyond which they can cause issues that can lead to recurrent miscarriages or recurrent implantation failures. And this is a problem because there is no generalized consensus, and this is the main issue why immunology in general is so conflicting nowadays. Just a minute, because I cannot change the slides for some reason.
I can see that maybe it's just stuck for you for a minute, so please just give it a second, because I can see you are changing them, so we can see that. And which one do you see right now?
In the main screen, I cannot see the... here it is. Okay.
Give it a few seconds, I should be okay.
Yeah, let's continue. So about the uterine natural killer cells, as we said, that are biologically very important for the implantation. But I mean, the clinical evidence that the abnormal natural killer cells, either in the blood or in the endometrial, can cause IVF failure by the research and about all the randomized evidence that exists nowadays. The truth is that it is the evidence weaker and inconsistent. So the main bodies, and this is something that we need to explain to the patients that are going through immunology therapies, like ESRE, like the American Society, do not actually recommend them. But there is a reason of that. And when someone is doing immunological testing, it doesn't mean that shouldn't do it. And in the next slides, I will explain why the evidence is inconsistent so far and why it cannot be recommended by the official main authorities. Okay, so I have a difficulty in changing the slides. I don't know why, but I will try to go this way. Why should someone bother about immunological testing? First of all, it's not for everybody. Someone that is having IVF shouldn't do immunological testing. We do this testing in specific category of patients, like patients that have recurrent implantation failures or recurrent miscarriages. And we don't do it even in these patients, in all the patients that have recurrent miscarriages, because there are much more common reasons of causing miscarriages and failing implantations than immunology. And first, we need to check about this. And then, if things keep going bad, conclude into having immunological testing. Because immunological testing does not have conclusive evidence. It costs quite a lot of money, all these tests. So we need to advise these things to the patients, to consult them, and to make a consented decision about proceeding with all these tests. And first of all, before we proceed to these tests, we need to check the embryo. The main reason of miscarriages and failing implantations is the chromosomes of the embryo. We cannot really go ahead and checking about immunology if we don't know that we have a healthy embryo. Chronic infections, for example, which can be identified with hysteroscopy and relevant testing, like endometritis, is a more common reason of all these things and needs to be checked initially. And if we still keep failing and having problems, then we need to check about immunology as well. And the reason is that euploid embryos, chromosomically normal embryos, are too precious to risk them. And sometimes you only get one euploid embryo. And it is a pity not to check everything in women that have relevant history. There is data regarding immunology. It's not that there is no data. And there is some conclusive evidence behind it that when you deal with it properly, it can help. The problem is that we need to personalize the approach, even if the data is non-conclusive. And the truth is that the data is non-conclusive because it has inside different trials from different approaches, everything together, blood immunology, endometrial immunology, not personalization inside, and the result is never conclusive because of that. But if you really know reproductive medicine, if you really know immunology, you know how it works, and you know that every medication that you give can affect the immunology inside the lining of the womb. And by treating the approach of immunology this way, you can really offer advantages in people that really have a problem. So how do we check? It's either blood tests. People might have heard about Chicago test or similar blood tests that are in the market. When we check the blood natural killer cell tests, we use a method which is called cytometry, flow cytometry, to measure actually the percentage and the activity of the natural killer cells in the blood. The problem is that what is happening in the blood does not always correspond, as we said, to what is happening in the uterus. They don't behave identically. And then we have the endometrial, the uterine natural killer cell tests, which though need a biopsy. And in this case, when we take a biopsy, we analyze them either with flow cytometry or with immunohistochemistry, which is a different method. And we assess again the same thing, only in the uterus. What we prefer, very conflicting. In our unit, we prefer to do the biopsy, we prefer to do the uterine tests, and there is a reason of that. It's more directly relevant, even though it is indeed more invasive. Okay, let's have a hypothesis. And the hypothesis is that natural killer cells can help in the implantation, but when we have excessive natural killer cells, this could attack the embryo or impair actually the implantation. The evidence is mixed. Some studies suggest an association with recurrent implantation failures or miscarriage. Others find no consistent link. The truth is that when we have a problem, there is a clear theory behind it of how it should affect. There is another theory that says that the uterine natural killer cells, that's natural killer cells that exist inside the lining of the womb, are usually supportive of implantation, and the high levels, for example, of these natural killer cells, it's not an immunological problem, but it is a reaction to the endometrium. So, for example, if the endometrium has got an infection, or if the endometrium has got an environment generally of endometriosis, all these things can cause an inflammation, and this inflammation, as we will see later on, can cause changes in the immunology. Immunology, of course, is a very broad thing, and it's not only natural killer cells, which are the most common cells that we know. Many autoimmune conditions can affect generally. Lupus, sometimes it is, we don't know that we have it, and the people, subfertile people with recurrent miscarriages, find it out only because of the miscarriages. Antiphospholipid syndrome, Hashimoto thyroid problems. When we have an autoimmune background, generally, all this is associated with deranged natural killer cells in a very big percentage in the blood and possibly in the endometrium too. Then we have some other antigens and antibodies like the HLA and KIR antibodies that we will talk about later, and also they might play a role. And we might have all these indicators actually, which are indicators of the uterine natural killer cells maturation and activity, with the weird names like interleukin 15, fibronectin 14, interleukin 18. All these things maintain a balance inside the endometrium. And when this balance is deranged, they can cause issues with recurrent miscarriages, of course, after we have excluded all the more common reasons that we talked about before. At Pelargos IVF, we have investigated thoroughly some studies from a French immunologist who is called Nathalie Leder. Generally, our approach in many things is very personalized, and we try to maintain that even when the work is going more and more, because we believe that every case is different, and immunology is the same. Leder believes that checking the endometrium is better than checking the blood. Also, we need to check at a specific period of time, which is the luteal phase, the second phase of the cycle, which is when usually the implantation happens. If you check at a random stage, the immunology will be different from the time that actually the embryo transfer happens at the time of an IVF. The hormones that we give for a frozen transfer or a fresh cycle can change the immunology. The immunology in the endometrium can also change even in 6 months. It doesn't stay the same. A pregnancy can change it. Hormonal imbalances can change it. Endometriosis can change it. PCOS can change it. Chronic infections can change it. So what do we mean by saying personalized approach? We mean that the endometrium can be, at the time of the embryo transfer, at the time of the implantation, either overactivated or underactivated, or it can have a mixed profile. When we are talking about overactivation, we are talking about increased natural killer cells activation. We are talking also about dominance of cytosins, which are called Th1, and we are talking about increased ratio of these markers here with the weird names. Underactivation, it means the opposite thing. And the mixed profile, it means a combination of these two. We need to know first what is happening at the time of the embryo transfer, when the implantation happens, to treat. Because many times we give steroids, we give intralipids, and we don't know what is the issue. Sometimes it might be underactive endometrium, and instead of making things better by giving steroids, we make it worse. So what is happening when we have an overactive endometrium at the time of the embryo transfer? We can give steroids. We can give intralipids if the steroids are not enough. We can give IVIG, which is a very nice medication, even though in Greece we cannot find it and we do not use it. Even the progesterone supplementation plays a role, because progesterone is not only a hormone, it's an immunomodulator as well. So by giving high doses of progesterone, you alterate the immunology. By giving lower dose, you alterate again the immunology. The same thing with estrogen. Sometimes we give vitamin E. And what we try to do with all this, we try to reduce the Th1 dominance, to reduce the natural killer cell cytotoxicity, to promote actually the tolerance to the embryo through the hormonal replacement of progesterone, to create new vessels, and to balance generally the cytosins. What is happening though when we have undersuppressive? That if we don't check about, we will not know what it is. It's a different thing. Here we don't have increased activity of the natural killer cells. So in cases like that, we use luteal phase scratching in the previous cycle that can cause a local inflammation and can help actually mobilizing the natural killer cells, because here the problem is the opposite. Or we can give HSG in the luteal phase, and this can help differentiating actually the immunology in the endometrium. We can adjust the progesterone supplementation. We can change the total levels of progesterone and estrogen when we talk about fresh cycles, even though in our unit, the very big percentage of the cycles is frozen. And the target is to mobilize the natural killer cells, to mature them, and to recruit them, and to improve the blood vessels. When we have a mixed approach, it's more complicated. Usually the theory in cases like that, it says that we go on the predominant factors, which are high, which are low, and in cases like that, we can adjust approaches of both of the previous categories. So use immunosuppression together with luteal phase adaptation, together with Ovitrel, together with HSG that we talked about before. Even Clexane, a very well-known medication, which is an anticoagulant. I have noticed that many times we give Clexane. Okay, sometimes we give Clexane for prophylaxis in women that are more than 40 because health is very important. All these things provoke blood clots sometimes, so it is okay to give them. But many times we give Clexane just because we give it, even if we haven't checked thrombophilia before. And it's not the case because Clexane is not only an anti-clotting medication, it's also an immunomodulator, which means that it helps promoting the placenta, it helps improving the blood vessels. So when we have, so what it does actually, it is also, apart from thinning the blood, it helps lowering the natural killer's toxicity to reduce the Th1 inflammation cytosines. Keep in mind that in the environment, without really complicating it too much, Th1 doesn't help, Th2 helps. So when we have an overactive environment, and we know that when we have checked it at the right timing, then Clexane is useful. But when we have the opposite, when we have an undersuppressive environment, Clexane might cause problems. I've talked before, endometriosis, PCOS, endometritis, chronic infection. All these conditions, apart from causing other issues, they can also alterate immunology because all these conditions are associated with something which is called inflammation. So endometriosis can alter the natural killer cells in the peripheral blood, and possibly in the uterus. It can cause inflammation. This means that it increases some cytosines. PCOS works with the same way. It increases, again, some cytosines. And chronic infection can cause a chronic inflammation. And again, it can cause changes in all these mechanisms that can implant an embryo. So when we have people that have a history like that, we need to have a lower threshold in checking immunology and checking personalized immunology at the time of the embryo transfer. And sometimes when we treat these conditions, we treat the immunology as well. People might have heard about Chicago test. It's the blood test. We don't prefer it. We use it in people that cannot do the biopsy, either for cost issues, either because they cannot travel to do the biopsy, either because in their countries, coming from abroad, they don't find the relevant test. Blood test shows again the natural killer cell activity, shows the cytotoxicity. It checks about ADTPOs, which is associated with Hashimoto. It checks about antiphospholipid syndrome. It checks about the HLA antigens and antibodies, about ANA, Th1, Th2. The problem with this test is that it doesn't always correspond to the uterine population, as we said before. It gives general explanations about an autoimmune status, which sometimes can be important. For example, if we find APS, we know that we have an immunological condition that is causing blood clotting issues as well, so we know what to do. But it can be used either additionally in people that can afford it, or instead of it, if the immunology test with the biopsy, which is called IMAP in our unit, is not possible. The test for the uterine biopsy, we use a test which is very close to the LEDES studies that we believe in. And this test is called IMAP. There are some other tests as well in the market, similar. But we think it's more closer to this personalized approach that we have decided to implement in our practice. The benefits of it is that you do a trial of embryo transfer and you check the immunology exactly at the same time that you would do at the time of the embryo transfer. So you give estrogen, you give progesterone, and you check at that time, because at that time, these hormones might have affected the immunology of the endometrium. We take into consideration the hormones. We check the uterus and not the blood, because the blood does not always correspond to the uterus. And we personalize the approach and the treatment. We give a protocol depending on the results. The disadvantages is that it is a sensitive test, so sometimes we don't get the results, and this is a problem especially for people coming from abroad. It is an expensive test, and it is intrusive because it requires a biopsy inside the lining of the womb. HLA-KIR. You might have heard, people that have recurrent miscarriages have heard about it. Not conclusive evidence behind it. The big bodies like ESRE are not very big fans of it. What is HLA? It's a molecule actually that is expressed on the placental cells, the very early cells of a pregnancy. And what is KIR? KIR. They are receptors on the uterine natural killer cells in the mother that can interact with the antigens that come from the paternal side. When we have specific combination of HLA with specific combination of KIR, this can cause problems according to some studies and according to some theories. The main problem is when the maternal antibodies in the natural killer cells are AA, and the fetal HLA is C2, which comes from the paternal side. So this is associated with impaired trophoblast invasion. It is associated sometimes with recurrent implantation failures, with preeclampsia, with miscarriages. Generally, I don't want to complicate you more on that, but the whole theory behind it is that when we have too much inhibition because of that, we have poor placenta creation, and we have an imbalance in all the factors that can cause implantation of an embryo. We check it with a blood test. We can check the maternal side to find out what exactly is the KIR, and we can check the paternal as well to see if we have a specific category of HLA. This is done with a blood test and with an analysis which is called PCR. And what we do in cases we find things like that, let me tell that this is something that we don't always see in the immunology testing that I was talking before, which is called IMAP. And we only do it in women that we have done everything else and we cannot find an explanation. And we only do it in women that have recurrent implantation failures or recurrent miscarriages. So, I mean, for example, if someone goes with a donor, we can check about finding a donor that will not have the SE HLA. When we have our own eggs, we advise single embryo transfer so that we can minimize the HLA-C antigens inside the uterus. We can use a medication which is called GCSF. It has some evidence and it has worked quite nicely in similar cases with us, so we do use it. It's something that improves the endometrial receptivity and the uterine natural killer cells function. We don't do LIT treatments, lymphocyte treatments, because they don't have any conclusive evidence and they have some risks, and we don't want to put people into risks without a conclusive evidence. We can combine the treatment together with IVIG or intralipids, and we can also alterate the progesterone, giving high doses of progesterone to promote an environment that will be more tolerant to accept the pregnancy. I'm finishing. Immunology needs to be checked. This is something that we need to be very careful after we have ruled out all the other more common factors. And only if we keep failing after we have checked everything else. We check it only in specific category, which is recurrent implantation failure and recurrent miscarriages. we prefer in our unit at least the uterine tests. The HLA-KIR can be added in a specific category of patients. The blood tests to be used in combination with the biopsy, it's possible if someone can afford it, and we can use it instead of the biopsy if we have logistic problems in doing the biopsy. There is no conclusive evidence, and you need to know that before you proceed to all these treatments. There is a lot of data, though, and by personalizing the approach, we have a very nice theory behind it of why it should help. We need to know, finally, every medication that we use, what it does in the immunology as well, because it's a very common thing that we use medication without really knowing why to use them, without really knowing what they cause to the immunology. And many times we give medication that can cause bad rather than good in people and in women that have immunology issues.
Thank you. Thank you so much indeed for your presentation. Lots of details you've explained. And as we mentioned at the very beginning, it's never an easy topic. So thank you so much for bringing this up. And I know that it definitely is many times confusing. So thank you. And of course, now it's your time. And if you have any questions, you can type those in the chat. I do see some questions here. So we will start answering them in a minute. But before we do, let's make like a short summary so everyone has a little bit more time also for their questions. If you can tell us about you mentioned the tests that you are doing, and sometimes there are tests that you advise to do, but some are simply, it's better to do them like biopsy, but you mentioned also Chicago test. And how does it work exactly? So what is like is there like one test that can check the NK cells and level, and when is it really recommended?
I mean, there are many tests. You can check in the blood, you can check in the uterus. For the reasons that I've said before, we prefer to check in the uterus, and also we prefer to check after we have prepared the endometrium with hormones so that we can mimic the environment at the time of the embryo transfer, because estrogen and progesterone can affect the immunology. When we do a blood test, we do it at a random stage, and we don't know for sure that this corresponds to what is happening inside the lining of the womb. So in our unit, we prefer to do the biopsy test, a test that we have found in the market that it is very close to the studies of the French immunologist that I mentioned is called IMAP. Mm-hmm. And we do this test to check about natural killer cells and about all the other factors that I've mentioned before, Th1, Th2, interleukins, to find out about the immunology exactly in the endometrium at the time of the embryo transfer. So we prefer it in comparison to the blood tests. Okay. And also, as I said, we don't check these things to everybody. We check these things to people that have recurrent implantation failures, recurrent miscarriages, and also after they have checked everything else, because it is completely silly to spend money in these tests that do not even have conclusive evidence for specific reasons and put back an embryo that it is not chromosomically normal. And it is not checked about chromosomes, because this is the main reason of why someone is having a miscarriage. So you need to rule out all the things that we have more conclusive evidence, and then if it keeps failing, we go to these tests.
Okay, thank you so much. That makes sense, of course. And I think that still many clinics do not follow the same rule. That's the truth. So thank you for bringing this up. And there's sometimes I also hear about this kind of question. So is there a connection between TSH levels and NK cells?
TSH?
TSH, yes.
Yeah, listen, TSH levels, we say that usually when we talk about IVF and embryo transfers, they need to be less than 2.5, which is the limit that we have put. Of course, we needed to check the anti-TPOs and to check and make sure that we don't have Hashimoto disease, because this is where the TSH needs to be less than 2.5. And Hashimoto is an autoimmune condition. And we know that all the autoimmune conditions many times are associated with other autoimmune conditions. And we know that in women that have an autoimmune condition, we might see in more percentage problems in the natural killer cells. Okay, it's not de facto, it's not that definitely we will have the problems, but we have a lower threshold in checking about all these things in women, of course, that have miscarriages or implantation failures.
Brilliant. Thank you so much for answering that, because I do see a question that is actually on that topic as well. So let me go straight to that one. I will display that for you. Sorry, not this one. I meant first one, this one. I mean, let's start with this one. So given hypothyroidism and Hashimoto's, should I consider checking NK cells before starting another round of IVF? My first round did not result in blastocysts. I have not completed the transfer phase. This is what we have.
Yeah, to be honest with you, if you don't have a history of miscarriages, if you don't have a history of implantation failures, and in your case, you didn't have an embryo, a blastocyst, so you didn't have a transfer, so you don't drop into this category. I would really go ahead and check my full immunology about natural killer cells just because you have Hashimoto. Hashimoto is a very common disease. I would just try to bring the TSH levels less than 2.5, create an embryo, which is the most important thing in your case, and go ahead without really checking all these tests.
Okay, thank you. Thank you so much. And as we can see, there's an answer from our patients as well. Thanks a lot. I'm glad that it was helpful. And let's have a look at the very first question that we got from Caitlin. What do you think about anti-HLA class 1 and 2 antibodies? Do you take them into consideration?
Yeah, I've talked in the presentation about this. We do take them into consideration. There are specific tests that we can do in regarding that. These antibodies and antigens are not seen in the IMAP test that I was saying before. It's an additional test in women that do have unexplained failures of implantation and continuous miscarriages after you have checked everything else. It is a test that you can go ahead and use it. Again, it doesn't have conclusive evidence behind it, but it has a nice theory. There is not even a proven treatment if you find out about this, but there are suggestions by the science that might help. For example, the single embryo transfer, immunomodulation with changing the progesterone levels, giving the Neupogen, which is a very nice medication that has helped in our practice in women that have it before. So we do it, we offer it, but in a specific category of patients, not to everybody. Yeah.
Okay. It's important to note that as well. And let me go to Jenny's question. What specific type of biopsy do you recommend to test for NK activity immune issues?
Yeah, I mean, in our unit, we use a test which is called IMAP, which is an endometrial biopsy test. And you do it after you prepare the endometrium with estrogen and progesterone to mimic actually the protocol that you will choose to do at the time of the embryo transfer and find out about the immunology at the same time with the same hormones so that you can use the relevant protocol that is suggested by the test depending on the results.
Right. Okay. Thank you a lot for that again. Claire has another question. If you have more, go ahead, type those in. Okay. I was diagnosed with NK cells after many failures. I was put on Queen program, I'm not sure, taxane, which resulted in our successful pregnancy and a baby. So, okay. That's
very
good
nice.
To hear.
Good. Yes, it's medication that we use in cases that we have overactivity of the endometrium. So it worked. It might have helped.
Okay. All right. So basically, those are the things that you are also using in your unit.
We use similar things, not exactly the same.
Okay.
There are some medications that have a better safety profile, and we prefer to use, regarding immunology, medication that have a better safety profile in comparison to medication that they are not that safe. If we need to use them, we use them. But for example, all this medication can have some side effects. For example, Neupogen can cause an increase in the white blood cells. It needs a monitoring. IVIG, for example, which we don't find it increase, so we cannot use it. It's a very nice medication, but you can very easily have an allergic reaction. You can very easily have issues with that, and we don't take actually the responsibility in using treatments that are not approved with a very difficult profile. We prefer to start from medication that will be safer for you as well. Yeah.
Oh, very nice. Okay, thank you so much for bringing this up. And in the meantime, I would like to ask you, because sometimes I think people are very often are wondering, because we had questions on IVIG, I remember many times. Can you tell us and explain, is IVIG the same as intralipid?
No, it's different. We use intralipid a lot. Intralipid has a much better safety profile than IVIG, and it is easier to find it as well. I mean, in Greece, we have a big problem to use it. And I mean, when you use IVIG, the right thing would be to have at the same time monitoring of your blood tests with an immunologist, rather than use it like that. But I mean, in Greece, we don't use it. We have very good results, though, with combination of steroids or Placanil, which is also a medication that we use instead of IVIG, with better safety profiles.
Okay. And regarding intralipids, are there any pros and cons on that?
Always there is a possibility of reaction, so you need a bit of monitoring when you have it. Usually it has a quite safe profile. We don't use intralipid just to use intralipid. Okay, we use intralipid when we know that we have over suppression of overactivity of the immune system in combination with steroids or instead of steroids, or when steroids are not well tolerant, so we can use the infusion of intralipid. And many different approaches as well on when exactly to use it. We use it usually about 5 days before and the embryo transfer, and we use it after the embryo transfer as well. And when we have a positive test, there are different protocols regarding intralipid on how to use it.
Of course. Thank you so much. I don't see more questions, but of course we still have a few minutes. So if you have more questions, go ahead, type those in. If not, we will be finishing, but I do believe it was very useful already for you. Dr. Harry, thank you so much for answering all the questions, but of course for your presentation. We might be finishing soon. So is there any final advice you would like to share with everyone today? Regarding our topic, of course.
Nothing. I mean, immunology is not the most important thing to look in IVF. But it should, my personal opinion, because we have looked in depth, is that it should be taken into consideration. And if you go step by step in all the studies and the randomized trials, you will see that there is a very big variety on what exactly they check and what exactly are the normal levels and the abnormal levels. But if you look it a bit deeper, you can personalize it. And what I want to say is that first you check the most common reasons. You exclude the most common reasons, and if you keep having failures, you go to immunology and you check it on the right way to know first what is happening inside the endometrium and use the right approach after that. Because people are using medication without really knowing what is happening inside, and you actually might cause worse rather than better things if you don't do it personalized.
That's very true, of course. Thank you so much. In the meantime, we did receive 2 more questions. Let's go ahead and answer them. Do you think it is important to check the KIR of a potential surrogate?
I mean, I think that not. Uh,
Mhm.
I think that not. Surrogates are usually women that have given pregnancies before. I mean, I think in the extreme edge of checking a surrogate as a baseline test. I mean, at least in us, because we are doing surrogacy as well, we don't.
Mhm. Yeah. Okay. Thank you. Thank you for that question and answer. I used steroids and intralipids with donor egg, had a successful outcome. I want to go again, but don't want to do intralipids. I tolerated steroids okay. Any thoughts on that from Danielle?
Uh, I don't know the reason of why you don't want to use intralipids again. Of course, keep in mind, as I said in the presentation, that immunology changes. So what happens before your previous pregnancy doesn't mean that it is the same now. And I don't know why you have used it exactly. I mean, have you done some tests and you had specific abnormalities in the immune system and that's why you have used them? It depends on what exactly was happening. If you had an overactivity of the immune system, you had increased natural killer cells, increased cytotoxicity of natural killer cells, Th1 towards Th2 ratio, for example, intralipids would be important in combination to the steroids. If you used intralipids just because it didn't work initially and someone put you into intralipids, I'm not even sure that intralipids was what it got you pregnant, so you could possibly avoid it.
Okay. Thank you, Daniel, again for that question as well. And let us know. I hope that was useful. I do believe so. And I think that was our final question for today. So thanks everyone for being with us today. I do believe it was useful. Dr. Harry, thank you so much. It's always a pleasure to have you here for sure. As you know, we have some more events coming up. So thanks a lot. As you can see, more thank yous are coming up your way. Yeah, thank you so much. Dr. Harry Karpouzis, Scientific Director and founder of Pelargos IVF in Athens, Greece, has been our guest once again. I'm really looking forward to some more events with you. And thank you so much. It was really interesting and not an easy topic. So thanks a lot. Have a lovely evening, everyone.
Thanks a lot.
Anything else?
Nothing. Nice to see you, and I hope I helped.
I'm sure. Very informative. I couldn't agree more. So we will finish for today. But of course, as you know, we will be back with some more events with Dr. Harry as well. Tomorrow we will be back and we will discuss freeze-all strategy. And we have 2 speakers, 2 special guests, 2 fertility experts. So please join us. You can go to myivfenses.com and you will find out more about all our upcoming events as well. Of course. Thank you so much. Take care and see you soon. Bye.
Bye.